Chris. So hello.
Yes, Mark.
We are very pleased to be with you, with all the attendees through the world. And so I'm very pleased to manage the chair with Christopher Core. And so Christopher, thank you to be with you. Maybe you can ask for the first presenter if you want. Maybe if you want to introduce yourself, but everyone know you from Singapore.
Yeah, thank you, Mark. Very, very kind of you. Yeah, I'm a gastroenterologist from Singapore, and I do therapy and endoscopy. Very, very pleased to share this chairmanship with you of this session. Thank you, Mark.
So do I. Very pleased. Very pleased. So maybe you can call for the first presenter.
Actually, I'm supposed to introduce Isayama.
So you want to introduce Isayama? So I will introduce
Geoffroy. That was the plan. Sorry.
Okay, so Geoffroy. So I will introduce the first presenter with Geoffroy Van Bervlet from Nice, who is professor in Nice in the faculty hospital, and of course Nice is in France since more than 1 century.
Always.
Okay, so Geoffroy, you are going to speak about EUS guided biliary drainage in altered anatomy. So thank you, Geoffroy.
Thank you, Mark. So I try to share you my screen. I don't know if you got it. Yes. If you got it.
Not yet. Not yet.
Now. Yes or not?
No.
Okay.
I had the same trouble from my presentation. You remember? So you have to close the PowerPoint and to restart.
And now?
Yes.
Yes.
Yes, we can see it now.
Yeah.
Yes.
Sure. Is it good like this?
Yes. It's good.
Yes. This is good.
Okay, so thank you, Mark. Thank you all of the scientific committees for this very kind invitation. So I have to treat this question of the EUS guided biliary drainage in altered anatomy, and the first presentation I have to do it is concerning the definition of altered anatomy. You know that it is when the papilla is not accessible, and you lose finally the continuity between the stomach and the duodenum. And in this situation, Ercp is clearly difficult. And most of the time, it is due to surgery. And there is 3 different type of surgery which induce some difficulty. It is first the gastrojejunostomy, including the bile type 2, as you know. In this case, the Ercp is depending on the length of the afferent limb. Most of the time it is feasible, but it is sometimes challenging. The second situation, it is a Whipple procedure. And in this situation, you know that the biliopancreatic limbs could be very long and induce some difficulty to perform Ercp, especially with the duodenoscope. Most of the time it is impossible. And the last situation, it is today with a lot of bariatric surgeries, the Roux-en-Y gastric bypass. And in this case, you got a biliopancreatic limb, which consists of the duodenum and the proximal jejunum, which is connected to the alimentary or the Roux limb, which is distally through a jejunostomy connected to the biliopancreatic limb. The other situation include the acquired disease, especially the benign and the malignant structure, most of the time due to the duodenal involvement by a tumoral situation. So what are the different alternatives for the biliary drainage in this different situation? First, it is a surgical alternative. The first one was surgery-assisted ERCP. Today, it is this technique was abandoned. The second possibility, it is the laparoscopic assisted ERCP. It is certainly the best option when you have to treat the gallbladder during the same procedure, especially for bypass with common bile stone. But the problem is that it is an expensive procedure. You need a good coordination between surgeon and endoscopist, and if it is not always the case, and you have adverse event accumulate between the ERCP procedure and the surgery. The second type of alternative are first the percutaneous transhepatic biliary drainage, or PTBD, as you know. It is a widely available technique, cheap and fast procedures. Problem, it is only a short-term solution with significant risk of reintervention, and it induces a lot of hydric losses, and it is not a long-term solution. And the second technique procedure is the enteroscopic assisted ERCP, which is, as you know, recommended by the Tokyo guideline, but it is clearly a labor-intensive procedure, which is very expert-dependent, with a lack of dedicated material for the common bile duct manipulation. And finally, to resume, the last possibility is the EUS guided biliary drainage, which is available for all different of this situation. And we will have a small word from the hybrid technique. I mean, the technique which allows to restore the duodenal access by EUS guided procedure and associated to a classical ERCP using a duodenoscope. And we call that it's the age for EUS-directed transgastric ERCP, especially for bypass, and the EUS-directed transenteric ERCP for altered non-1Y gastric bypass anatomy. How you have to do a EUS-guided biliary drainage? There is 4 different techniques which are described in the literature. The first technique are transpapillary one with the rendezvous technique and the anterograde state placement. These techniques are available only if papilla is accessible. And the good point, the green point for these transpapillary techniques is that it is anatomical access preservation, but it induces multi-step procedure with cumulative adverse event, as you know. The second type of procedure is the transluminal technique with the coedoco duodenostomy. The problem with this technique is that you need to access to the duodenum to perform it. And the second one is hepaticogastrostomy, which is widely usable for surgical altered anatomy. But in all of this case, it is a therapeutic EUS procedure, so you need CO2 insufflation, general anesthesia, always antibio-prophylaxis, linear probe, of course, for the EUS procedure, a 19-gauge needle, and all the different ERCP material, including lumen opposing metal instant, if you can. What about the results, especially for the transluminal techniques? We have some recent meta-analysis to give you a good view of the performance of this technique. We know that transgastric and transduodenal drainage are very successful, about 19.2 to 19.4% of cases in this meta-analysis published in 2017, with always a significant morbidity in the past, about 20 to 25%. And we know that there is a great learning curve for this EUS-BD procedure, and a single center in France was published 5 years ago. This procedure showed that the hepaticogastrostomy especially was a very efficient technique, with a technical and clinical success very high, upper than 19% of cases. But the rate of adverse event and the rate of morbid mortality was clearly dependent of the learning curve and of the period of performance of the procedure. So what is the better route in this situation? Is it intrahepatic or extrahepatic access? For the intrahepatic route, we know that the needle traverses the peritoneal cavity, so there is certainly a higher risk of stent migration and biloma formation. We know that there is a higher risk potentially of bile linkage, and it is totally different for the extrahepatic access. And in this situation, you are more close from the duodenum and from the dilated bile duct, and you are in an area which is relatively fixed with a minimal respiratory influence. And finally, when you have to look at the result which compares the hepaticogastrostomy or the intrahepatic access versus the extrahepatic route, clearly the comparative evaluation, especially in this review of literature, show that efficacy is close to be similar, but there is a tendency to lower adverse event rates when you use the extrahepatic route. And this was confirmed by the last published study and series, especially when you use a lumen apposing metallic stent. And in this French multi-center retrospective study, it was the Axios platform. You can see that in this series, which included 70 consecutive patients, the mean duration of the procedure was about 5 minutes, with a very high technical and clinical success rates and only 3% per procedural adverse event rate. So it means that choledochoduodenostomy is easier, but choledochoduodenostomy is not always possible. Effectively, hepaticogastrostomy and hepatico-access offers the anterograde technique and access. You know that it is a portal to allow the treatment, especially of the benign structure in case of altered anatomy. And most of the time, it is a two-step procedure, and you can treat like this stenosis or structure of biliary jejunal anastomosis, especially during the Whipple surgery. And you can sometimes treat intrahepatic biliary stone using the same technique. So the first step is to accede to the left bile duct using an hepaticogastrostomy, and the second step is to use this access to treat the structure or the stone using dilation material, plastic stent, or even cholangioscopy, which have been widely described in the literature the last year. So when we have a look of the different results regarding this anterograde treatment, we can see that there is only small series, but always with very interesting results, especially with these two retrospective series, including 20 and 37 patients. You can observe that the clinical success was about 85% and more than 18%, with only few adverse events, even if biliary peritonitis are observed, especially with one-stage anterograde intervention. So if you can, most of the time, you have to perform with a two-step procedure to be sure that the link is really created and that you can do your different manipulation and procedure to extract the stone or to treat the structure during the second time. This is the result of from Mark with some data which will be published and which are submitted about 12 patients. You can see that finally during the first step hepaticogastrostomy, which was associated with 100% technical success, you can after the first step cross through the anastomotic structure in 25% of case. But the final success rate of treating the structure is about 75%, with only 3 cases of failure in this series, with an overall number of session of endoscopy of 4.2. The other technique which can be used in this situation of altered anatomy is the EUS rendezvous. The EUS guided rendezvous have been widely evaluated in the literature, and I show you in this table the result of the most large series which was published recently. You can see that the result when you compare the group of patients with altered anatomy or non-altered anatomy, these both groups are totally comparable regarding the success rate of bed puncture, cholangiography, technical success rate, and complication rates. And these results are not influenced by the different approaches which have been proposed for this technique. Finally, if you have a look on the review of the literature inside this same publication about more than 200 published cases, the overall success rate is about 80% with an overall complication rate of 11%, which is quite low. Other question which is very important and interesting, it is to compare PTBT and result of PTBT with the EUS guided biliary drainage, especially in altered anatomy. And you can see in this meta-analysis that finally, if the similar technical success rate are obtained between both of these techniques, finally the EUS guided biliary drainage induce better clinical and technical success, better fewer adverse events, less reintervention rate, and finally better cost effectiveness. So I think that the question is closed. EUS BD is clearly the best option compared with the PTBT. If we jump to the other question for the comparison between enteroscopy ERCP and EUS guided BD, we know that in this review of literature regarding the enteroscopic ERCP with overtube assisted system, that the rate of success finally is quite low, about 70% of cases, and it is induced even when you use a spiral system or double balloon system to the access and not to the ERCP procedure. And it is a very huge and difficult procedure, labor extensive procedure with a time of operative time of 18 minutes in means, which is very high. And in this last comparative retrospective study, you can see that finally the EUS guided biliary drainage induce a reduction, a significant reduction of the procedure time, of the procedure duration, better technical and clinical success were observed EUS guided biliary drainage, but a significant increase of adverse event was observed with the EUS BD compared with the enteroscopic ERCP. And finally, what can we say when we compare even if patient presents with non-altered anatomy or altered anatomy, especially in malignant structure of the distal bile duct? There is about 10 meta-analyses which were published these last 5 years. And this is a result of the two last one. And you can see that when you compare ERCP and classical ERCP with EUS BD, there is no difference regarding the technical and the clinical success. But it seems that there is a lower rate with EUS BD of reintervention in this meta-analysis. And if we only focus the result on the randomized controlled trials, and it was the topic of this last meta-analysis published 2 years ago, we can observe that the EUS BD decreased the risk of stent dysfunction in the time, decreased the risk of post-procedure pancreatitis. And we understand easily why, and no difference were not in technical and clinical success between ERCP and USBD. So this is now the typical innovation of US guided procedure. It is a hybrid technique with the edge procedure. The edge procedure, you know, is this procedure which was used to perform URCP, classical URCP after a bypass. With a lumen opposing metal stent, you allow to restore the continuation between the gastric pouch and the excluded stomach to perform a dilation, and then pass through the exhaust platform and go in the duodenum to perform the URCP. And the other technique is the US directed transenteric URCP, which is performed always using a lumen opposing metallic stent to accede to the afferent and the biliopancreatic limb using a colonoscope or gastroscope after insert an axial stent, and then performing the URCP and treat especially the anastomosis between the bile duct and the jejunal loop. These hybrid techniques are now published widely in the literature. There is a lot of comparative study, but it seems that the edge became slowly the gold standard for the treatment of the biliary issue in patients treated by bypass. Some retrospective comparative study show that the edge seems to be to present better success rates compared with enteroscopic URCP with a shorter duration and comparable safety finally. And edge was recently compared with laparoscopic assisted URCP with no difference in technical clinical success rates and adverse events, with a shorter total procedure time and a shorter length of hospital stay. Regarding the US directed transenteric URCP, it seems that the first series show a high technical success rate and a rate of clinical success in more than 19%. The simple issue, it is the median total procedure, which is quite high, but the results are very impressive for the future. We need now some very good and large, certainly prospective study to give a definitive result. So in conclusion, USBD seems to be better than ERCP enteroscopic treatment or PTBD in altered anatomy, clearly. The anterograde USBD is relevant when you perform, when you have to perform treatment, endoscopic treatment for benign condition. Choledochoduodenostomy, if possible, with LAMS is to prefer due to a very simple technique, especially in expert hands. But we need now some comparative study, large comparative and prospective study, and always an expert, and because we know that the learning curve is quite huge. And best conclusion certainly is the last conclusion of the ASEAN-US group guideline, and this is the two last statement of this guideline. USBD is recommended as a procedure of choice for biliary drainage in patients with failed URCP if expertise is available. And the second statement, the last statement, was USBD is an alternative procedure to obtain biliary drainage in patients with altered postoperative anatomy or duodenal stenosis, precluding URCP if URCP is available. My last slide, finally, it is a proposition of algorithm which was presented by the team of Mohamed Kashab, and which is very interesting. And you can see that finally you can evaluate the technique you have to use depending on the presence or the absence of bariatric surgery. In this case, certainly the age is the best option. If not, and you have to evaluate it, the possibility of US guided rendezvous. And if it is not possible, you have to switch to US hepatico-gastro or hepatico-jejunostomy. And in case of failure, the last solution will be certainly the transenteric Ercp, and if not, the PTBD. So this was my last slide, and I thank you for your attention.
Thank you very much, Geoffroy, for the terrific, very comprehensive talk that's really covered the whole spectrum of altered anatomy. Now, I'd like to, we'll take questions right at the end when all three presentations have been made. And now I would like to call upon and introduce Professor Hiro Isayama, who is
just
a
Hiroyuki
good
and
friend
Christopher,
from
just
Tokyo,
1 second.
Juntendo University. He's the head and chairman of gastroenterology there. And Hiro actually doesn't need much introduction, really, because he has published so extensively in both therapeutic EUS as well as in Ercp. So I'll just hand the floor over to him, Hiro, to do your talk. Please begin.
Okay, thank you, my friend, Chris. And I'm very happy to join this meeting. So thank you, Mark and Mustafa, to give me a good chance. So I will talk about EUS-guided both biliary and pancreatic procedures. So now I'm going to share the my slide. So can you see?
Yes, we see your presentation and we see your slide.
Can you see now?
Yes, Hiroyuki, we saw your slide.
Okay, I will start my presentation.
Yeah.
Okay, it's okay?
Yes, it's okay. Perfect.
Perfect. Okay. So, so my title of the presentation is the EUS-guided biliary and pancreatic intervention, now challenging Ercp. So this slide shows the requirements for EUS-guided interventions. So first one, establishment of procedure. So require high success rate, acceptable incidence of adverse event, and establishment of the reintervention. The very important thing is the management of adverse event, early detection, troubleshooting, and prevention of AEs. And same procedure as Ercp. It's very important. Higher biliary suture and preoperative conditions. And recently, we performed pancreatic interventions, but still, these are very difficult. Firstly, I want to talk about EUS-guided biliary interventions. Firstly, EUS-BD. We Japanese can perform EUS-BD under the governmental insurance. And we provided already the EUS-BD guidelines. So from these guidelines, the main indications of EUS-BD is undetectable and very important thing, salvage for failed or difficult Ercp. So EUS-BD is basically a salvage procedure. This is our recent VTR procedure performing the EUS-CDS. Puncture with a 90-gauge needle, the common hepatic duct, and injection of the contrast, insertion of the O2-5 guide wire, and dilation of the puncture tract with Bougie dilator, and subsequently insert fully covered Warflex. Fully covered Warflex has a very good delivery system, no requirement of the additional dilation. So, and now we are deployment fully covered Warflex. And a very important thing is intra-channel deployment, then push out. And this is a basic technique of ESCDS. And now I change the direction of the stent to the second portion. We performed CDS as a primary drainage, Japanese prospective multicenter trial. We encoded 36 cases, very high success rate and acceptable complication rate. And we think ESCDS is suitable for primary biliary drainage method. And recently, many doctors can use hot access for CDS. In Japan, it's not available for EUS guided biliary drainage. We use only for pseudocyst drainage. And I use this hot access for ESCDS, only 2 cases for the clinical trial. Actually, 5-minute procedure. It is very easy. I think that it is easier than Ercp, biliary cannulation. This slide shows our result. Dr. Suture, Tokyo Medical University, published this data. So this is very good. And from Korea, they published the RCT, ESBD versus Ercp as a primary biliary drainage method. From their result, so technical feasibility, ESBD equally Ercp. And the stent patency, patient QOL, adverse event superior in ESBD. From their result, the ESBD is suitable for primary biliary drainage method, but they have all-in-one devices. So then they perform ESBD very easy. So then I think that we have a dedicated device. We can perform the ESBD as a primary drainage method. We don't have a dedicated one. So this slide shows a ES-HGS case series that we performed ES-HGS with very long stent, modified geoball, 110 cases. We employed very long stents, and median intragastric stent length is 54 millimeter, very long. We think so. Very long portion in stomach is very safe. So this is our analysis. We compare the before and after CT, and we measure the distance between the liver and the stomach. So from our result, so after the HGS, so gastric wall will return to the original position. We cannot control the puncture point, and we should use a very long stent. And this slide shows our management of the AE, so early detection. We routinely take a plain CT on the next day of the interventional EUS procedure. So sensitivity on the accuracy of abdominal plain CT is very high. It is better than symptoms. So sometimes abdominal X-ray cannot detect very scarce situations. So this is our follow-up strategy. So after intervention, yes, if the patient complains severe symptoms, immediate enhanced CT will be taken. But no severe symptoms, routine plain CT, and according to the findings of the CT, we decided to follow up of the base observation or perform the additional procedure. It is very useful, we think. So, and if we encounter these scarce situations, we can perform some types of the anchoring with stent and anchoring with flap, named the clip flaps. But recently, we have a very good stent. We developed this stent with Teon medical devices named spring stopper. So this is a very, very good anchoring. Recently, we are evaluating this stent. We performed the EUS-HGS with a spring stopper over 40 cases and experienced no migration. So this is an experimental study. We are analyzing the anchoring force, and the spring stopper are very high and higher than the axios. So from our result, spring stopper is stronger than the axios stent. Then we sometimes we encounter these chaos situations, but it is safe. So we think spring stopper is very good. So, and this is our recent EUS-HGS procedure using a WOW mode. So fluoroscopic mode, WOW is a wire optimum weighted imaging. So it is a subtraction of the background. So we puncture the B3 with 19 gauge needle and injection of the contrast. Sometimes contrast overlapped with the supine, but a switch to the WOW. So we can see the wire very good. So subtract the supine bone, we can see the guide wires and the devices is very good. So recently we performed the EUS-HGS with a WOW mode, and it is a very good fluoroscopic mode published by Hitachi. Recently Hitachi changed to the Fujifilm Healthcare. Please ask to Fujifilm staff to get this machine. So recently we use WOW mode and use spring stopper for EUS-HGS, and we perform EUS-HGS easier than the previous and safer than the previous HGS with no good anchoring stent. So this is spring stopper. Okay. And I want to talk about reintervention. So reintervention, we can perform the stent-in-stent technique, and sometimes through the mesh technique, and sometimes a trimming of the metallic stent with APC. And move to the US-guided stone extraction. It is not so high success rate published. This is our series, very high success rate and higher than the double barrel Ercp, and shorter procedure time. Recently, we are performing the RCT, comparing the ES-guided intervention versus a double barrel Ercp for CBD stone cases with surgically altered anatomy. This is our technique. This case, we punctured the B2. So Achilles heel of this procedure is sometimes a very small dilation of the intrahepatic duct, and sometimes no dilation. So recently we can use a 22 gauge needle because Olympus company published 018 very good guide wire. Maybe this good guide wire will be sold in the world within this year or early in the next year. So now we are dilate puncture route along the 025 guide wire, and now we insert a double Garumen catheter and insert additional 035 guide wire. So this procedure, pushing ability is not so high. Then we insert a very tough 035 guide wire. And the balloon dilation, both papilla and puncture route. And subsequently, we try to push out the stones to the jejunum with the retrievable balloons. So pushing ability is not so good. Now, I asked to the Japanese domestic company, Xeon company, and to provide balloon catheter with tough shaft to perform this procedure easier. But actually, we performed this procedure with ERCP devices, and most of the case, we succeeded. Okay. And we can perform the POCS, so spyglass, after the maturation of the anastomosis. So now we are performing the EHL for the intrahepatic bile stones. So we insert first plastic stent, and second session place the 2 stents. After the maturation of the fistula, maybe 2 weeks or 3 weeks or more, we can insert fibers. And this case is a 5-year child. So we place 2 stents and keep the 2 stents about 1 year. So we successfully remove the stents after the dilation of the anastomotic stricture. So this is our result for the benign biliary stricture with surgical adult anatomy. So very good high success rate. And our strategy for dilation of the fistula and place a multiple plastic stent for 1 year. Now we successfully remove the 30% stent and ongoing 50%. And move to the higher stricture. We have some option to go to the right side. So transverse hilar stricture and go to the posterior branch and combined. Oh, this is EUS HDS, so hepatical duodenostomy, puncture from the duodenum first portion, and we successfully place a metallic stent. We can perform such kind of the procedure, but it's not easy compared with routine EUS HGS. And we can perform these trials to transverse. It is also difficult, and HDS also difficult. And the other option is combined with ERCP. Recently, Professor Prajamchai Konkam published a combined ERCP data. And it is very good data, and it is one of the options. But still challenging for management of the hilar stricture with EUS. And this is a pre-operative EUS CDS. Only one case report published by Professor Fujita. We should accumulate evidences. So move to the pancreatic. So ESPD, so still a very difficult procedure. And this is our recent procedure of the EUS guided pancreatical gastrostomy, EUS PGS. We puncture the pancreatic duct with 90-gauge needle. This case, the suffering from the recurrent pancreatitis due to the stricture at the pancreato-jejunal stomy. So we place a guide wire to the jejunum, and now we try to dilate fistula with a bougie dilator. And subsequently insert a balloon catheter and dilate anastomotic stricture and pancreatic wall and gastric wall. Finally, we inserted a double pigtail plastic stent. The first pigtail placed at jejunum, and second double pigtail placed at stomach. It is a very safe way to prevent migration. This case, we place one pigtail stent, and next session, we increase plastic stent 2. This is our ESPD procedure, a very high success rate, but a relatively high adverse event rate. And we place a multiple plastic stent. And next step, we inserted POPS into the pancreatic duct to crush the stones. So after the maturation of the puncture tract, we can insert spyglass and can perform the many procedures. So we experienced 12 cases of the spyglass through the EUS PGS route. So very high success rate, and we get many good findings. So this case, anastomotic stricture site. So there was IPMA. We cannot remove the stent, and now we are discussing with the surgeon and the patient. Next one is exposure suture within, and maybe this is one of the cause of the stricture. That we try to remove the sutures with a spy bite. So we grasp the suture with a spy bite and pushing the scope to the jejunum to remove the suture. Initially, surgeon told us, "Oh, it is a very safe procedure." So then we performed this procedure, and we one by one remove the sutures. And during the procedure, we wear the very small hole. So one perforation occurred. So we place 2 stents and finish the procedure. But this patient, no symptom. And finally, we successfully dilate anastomotic stricture. So very, very impressive case. Okay, ladies and gentlemen, this is my conclusion. ES-guided pancreatic biliary interventions is still salvage procedure, especially pancreatic interventions, but suitable for primary indications, surgically altered anatomy, EUS CDS. EUS HGS with dedicated devices, if you can. Requirements for establishment of ES-guided procedures. So all-in-one device is mandatory. And establishment of the troubleshooting, the intervention, and the management of the higher stricture required. Okay, thank you very much for the kind attention. I want to finish my presentation.
So thank you very much, Hiroyuki. Very nice and amazing cases, and a lot of way to treat these patients with the altered anatomy. So thanks again, and thanks for giving us some ideas, some new ideas for treating our patients.
Okay, thank you.
We can't hear you.
If you agree, Christopher, it's okay. You are with us.
We're not able to hear you.
You cannot hear me?
Is your microphone on mute?
No, mine is open.
Oh, now we can hear you.
Open. Do you hear me? Geoffroy, you hear me?
Oh,
And Hiroyuki,
your voice
you
has
hear me?
gone off again.
Yes, I hear you. Okay.
Okay. So,
Hiro, you can hear Mark?
Hiro and Geoffroy can hear me.
Yes.
So maybe your microphone,
I'm missing.
I can hear you very well, Christopher. Anyway, we have to move. We have to move to the recorded case.
Yes.
Okay.
And after we will have a common
But,
discussion with
go
everyone. Okay. So we move to the recorded cases and we try to repair your problem, Christopher. Okay. So can you start with the recorded case from Professor Sun? Okay, thank you.
Hello, everybody. I'm so happy to be here. I'm from Sunji Hospital of China Medical University. So thank you for your invitation, for giving me this opportunity to perform this procedure and discuss this case with so many friends. Now today I'll perform the procedure for the patient presented with pancreatic cancer with multi-hepatic metastasis. Now recently the patient was found with objective jaundice and received ERCP in our hospital, but it's so difficult to make it. So the patient was referred to our hospital for the EUS guided biliary drainage. So today I'll perform this alternative for this patient. Now we advance the scalp to the stomach. Now we have to bring the pancreatic body into view. This is section of the pancreatic body. In this section, we rotate the scalp to the right. We'll bring the pancreatic tail into view. When we rotate the scalp to the left, we'll bring pancreatic neck, pancreatic head, and the ascent process into view. The last place we could find dilated common bile duct. The last place, let's measure the diameter of a common bile duct. It's about 19 millimeters. Now we could find some lymph nodes here. I think it should be malignant. Now we are going to advance the scalp to the duodenum. Now the scalp has passed through the pylori and entered the first portion of the duodenum. In the duodenum, I would like to find a suitable position to perform this puncture to the common bile duct, but sometimes it's not always very easy. For this patient, it's very difficult to find a suitable place. At this place, we could find the dilated gallbladder and dilated common bile duct and cystic duct. Now we could find the gallbladder is very big, and it's very difficult to find a suitable puncture point to the common bile duct. Now here's a section of portal vein and common bile duct. I think this place is suitable for perform this procedure. In this section, we also can find this dilated cystic duct. Now, before we perform the EUS guided biliary drainage, we should discuss if we perform the FNA for this patient. But we know the diagnosis of this patient has been confirmed by a liver biopsy for this metastasis in the liver. And so the patient has received chemotherapy for a period of time. So I don't think it's necessary for the patient to receive another FNA in the pancreas. So today I will perform the EUS guided biliary drainage directly. Before they perform the procedure, we'll select a 19 gauge needle because only 19 gauge needle can pass through the 0.035 inch guide wire. So it's very useful. That's very important. And today we'll use Boston Scientific 19 gauge needle because it's a flexible needle. It's very suitable for performing the puncture in the first portion of the duodenum. When I introduce the 19 gauge needle, I find that it's so hard to find a good place to perform the puncture. The gallbladder is very big, and there's a lot of blood vessel. Wow, you can find the very big the gastroduodenal artery is very dangerous. If you cause damage to the artery during the procedure, it will be a nightmare. Because the common bile duct is very soft, so sometimes when I perform the puncture to the common bile duct, I would like to use explosive force. This means we lock the handle in a suitable place to set the depth of puncture, and then we remove the stylet. Now then we flap the handle of the needle and let the needle into the common bile duct like a narrow. Now we use a syringe to draw at least 20 milliliters of bile juice. Because the more bile juice we draw, the more contrast we can inject later. This policy is very important to prevent cholangitis after procedure. Okay, that's enough. Now we start to inject some contrast. Okay, that's enough. Now let's start to introduce the gateway into the common bile duct. This is a 0.035 inch gateway. Okay, it has entered the hepatic duct. The position is very nice. So let's exchange. Let's remove the needle. The endoscopy should hold the elevator to control the gateway. It's very important to prevent the movement of the gateway. And then in this situation, we also should rotate the scalp to bring the gateway into the ultrasonic imaging. We should observe the gateway uh, during the whole procedure because the gateway is the puncture tract. Next step, we will use the 6 French cytotome to dilate the needle track to create the fistula between the duodenum and the common bile duct. The 6 French was made by Indoflex, has been recommended by a lot of guideline to perform the EUS guided biliary drainage. Now we use the intercut eye current to create the fistula. It's not very easy. We have to be patient. Okay, we got it. We have introduced the system into the common bile duct. So we remove the cytotome and please prepare a metal stand, 6 centimeters fully count metal stand for me. Now we will implant Boston Scientific wall stand, fully covered metal stand for this patient. Because it's a rapid exchange delivery system, so the operator can hold the gateway and introduce the implanter himself. So it's much easier to deploy the stand into the target the place. When we introduce the implanter, we have to be very carefully and slowly. Now the implanter had now the implanter have reached uh, the right place. Now we try to release the stand. Okay, keep going. Keep going. Keep going. Okay. Okay, that's good. Okay, okay, keep going, keep going. Now we release the stand into the working channel at first. Then we push the stand out of the working channel. It's a very nice protocol to prevent misplacing the stand. Okay, that's very perfect. Okay, that's very perfect. That's very perfect. No, fluoroscopy, please. Okay, this is the conclusion of this procedure. I think EUS biliary journey has become a very important alternative for the obstructive jaundice after ERCP failed.
That was terrific video demonstration by Professor Sun Si. Thank you very much. Will he be joining us for the question and answer? Do you know, Mark?
Yeah, we can start the question and answer. Thanks to Professor Sun for this nice live recorded demonstration, but how to perform choledochoduodenostomy without lamps. Maybe we will have some question about that. First, we have some chat question about the two previous presentation. And the first question is, I think, very simple to answer. Do we need a systematic MRCP before treating hilum carcinoma?
In my practice, yes. And in my experience, yes. Because I have the feeling that MRCP with a good radiologist is give you a lot of important information, especially regarding the different topographic location of the structure and what the best plane you can propose by retrograde endoscopic approach or transluminal technique, or maybe rendezvous technique if you need. I think it is good to have a plane before to start your procedure to know what you will propose to the patient. Sometimes maybe start with EUS and then convert to ERCP with a rendezvous, or just to complete with an ERCP, or the reverse. And it is always interesting to have this kind of information, I think.
Okay, so maybe the take-home message will be always MRCP to plan the therapeutic strategy. Hiroyuki, what is your advice?
Yeah, okay, I will agree with Jeffrey. So I also got a MRCP before procedure. And currently, so mainstay is the ERCP for management of the hilar biliary stricture. And some cases difficult to perform ERCP, we perform the ESBD. and most of the case, so difficult to approach to the light. Firstly, I try to transverse hilum with the guide wire. If we failed, we try to perform the EUS HDS. I'm sorry. So sometimes I will combine with ERCP and PTBD. So the multidisciplinary management we tried.
Okay, so we have a very important question for the safety mainly about hepaticogastrostomy. Do you prefer to use plastic stent or metal stent?
Geoffrey?
Always fully covered metallic stent, and if possible, some specific one, as it was shown us by Hiroyuki, because I think that we need some specific design of stent to avoid any dislodgement or migration of the stent. But sometimes it could be a good question, especially for the benign condition and issue. And double pigtail and long double pigtail plastic stent should be used, especially when you have to treat an anastomotic stricture for hepaticojejunostomy, for example, etc. But if we speak about malignant biliary stricture, for me it is fully covered metallic stent.
So I agree with Geoffrey. Same so selection. So for malignant metallic stent, for benign plastic stent, very long double pigtail stent, and we have other selection. So it is a dedicated to plastic stent. One side is straight, and the stomach side the pigtail, and have many flaps. It is developed by Takao Itoi. So the many doctors recently selected this dedicated plastic stent.
Okay, there's another question about how to prevent migration of the stent for hepaticogastrostomy, because if you use fully covered metal stent, the risk is migration, usually intragastric migration, sometimes intrahepatic migration of the fully covered metal stent. So you use double pigtail metal stent, or you use clip of the metal meshes towards the gastric mucosa. What is your advice?
Me, sometimes when I have the feeling that the distal flange is not enough lunge inside the lumen of the stomach, I insert a plastic pigtail stent inside the fully covered metallic stent. And I try to avoid clip, because I have not the feeling that my opinion is that it doesn't work, but it is only my empiric opinion. I am not sure that there is any publication to evaluate the risk of migration, of the prevention and the efficacy of this technique to prevent the migration of the stent. I don't know what is your feeling, but I prefer to insert a pigtail stent inside the fully covered metallic stent.
Hiroyuki, you do the same?
Yeah, same. And I want to add my information. So we check the CT next day of the procedure, and check the relationship between stent and stomach. If we encounter the very scarce situation, very short length in the stomach, so we will perform the procedure and perform the clip flap now. Clip flap is performing the clipping of the stent body. So it is very useful to make anchoring.
Very sure. Christopher, some questions?
Yeah, there was a question about dilation of the access tract, and I know that Hiro doesn't like cautery dilation, and maybe we could ask both Hiro and Geoffroy, what's your preferred method of access tract dilation and why?
Geoffrey first.
Personally, I always use the six French cystostom to perform the access and for the hepaticogastrostomy, and I avoid any dilation technique, but I don't have any evaluation in my experience of the safety of both technique, because my own technique was the cystostom technique. So it is difficult to me to compare both of these technique. Maybe your experience would be interesting to hear for me, but me, I learned with the cystostom. So I use the cystostom, and I have the feeling that it is certainly safe. But I don't know what is your opinion and your feeling now.
Hiro, what about you? Why do you use dilation, balloon dilation, and not?
So previously we employed a cautery dilator, and because it is a very good tool, but we Japanese experience many severe complications, the bleeding, and I experienced perforation of the bile duct, and perforated to the portal vein, and both portal vein and hepatic artery, and many blood came out from the fistula. So after that, I firstly performed a bougie dilator. But in Japan, we have a dedicated dilator, very thin tipped dilator named EUS dilator. So it is a Xeon company published this one. And we firstly using the bougie dilator, and subsequently we insert a balloon catheter, and to prevent leakage. So minimum dilation is a basic technique. So we insert one pigtail or metallic stent, 4 millimeter dilation or 3 millimeter dilation. We have a very small balloon. So recently, many doctors employ the mechanical dilation first, and subsequently move to the cautery. It is now Japanese way. It is according to the availability of the devices.
Hiroyuki, the main problem of mechanical dilation is to push away your ductal structure, either the pancreatic duct, either the bile duct. So this is the reason for me, I prefer to use 6 French cystostom. And Christopher, what is your opinion? What do you do, Christopher?
Yeah,
mechanical dilatation or electrocautery?
So now I use mechanical first, because we have a good one.
Okay, perfect.
But previously we used cautery.
Maybe to my knowledge, in USA, the 6 French cystostom is not yet allowed.
Yeah,
only the 10 French.
They have no good dilation devices.
Yeah, I agree.
So we are very happy.
There is a chat question about the setting. If you do electrocautery dilatation, there's a chat question about the setting of the electrosurgical unit. I think this is very important. Can you give us an advice?
It is important to use as you perform a cyst drainage, to use the autocut current to be fast inside the bile duct, and to avoid any coagulation current. And the problem is that you can induce some bleeding, as said Hiroyuki, but the gold standard is to obtain the access fast and rapidly to be sure that you don't lose your guide wire and you don't push away the liver from the stomach.
Okay, so now we are reaching the end of the session. So, Christopher, could you give us some closing remarks and take-home messages from this session, please?
I think he had a bad connection. He had a bad connection.
He has a poor connection.
Yeah.
So maybe, Christopher, I apologize. I will do the closing remarks because I think you cannot hear me. So I just want to thank a lot Hiroyuki because of his amazing presentation with very nice cases, video cases, and Geoffroy because it was so didactic and so clear. So Geoffroy, I will take your presentation for me, for my own presentation because you have very nice slides. And Hiroyuki, thank you for your expertise also. And thank you and see you very soon. Thank you.
Yeah.
Bye-bye.
Bye-bye. Thank you very much.
Bye-bye.
Bye.